But others, such as Baroness Finlay, a crossbench peer in the House of Lords and a palliative end-of-life care expert, is cautioning against a law change. She's also chair of the all-party parliamentary group on dying well. She believes improved access to care and pain relief is the answer to end-of-life care, rather than taking lethal drugs. Baroness Finlay joins me now. Welcome to Woman's Hour. Thank you so much for coming in.
Thank you so much for asking me.
So as an advocate of maintaining the status quo in terms of the law, what is your reaction to what you've just heard from Dame Joan Ruddock?
Can I just say it's not the status quo. What we heard from Dame Joan is completely unacceptable. Nobody should be left in pain. Nobody should have the nurses walk out and not say, what are we going to do to provide pain relief overnight? In Wales, we've been trying to tackle this on a national basis, and we've been teaching relatives when we see somebody who's very near the end of life, in terms of the medication that they can give as breakthrough medication and how to give it, with a community drug chart there. This has been going since pre-COVID, and then during COVID it became a protocol because it was so urgent, and it's been quite safe. And we've also trained up paramedics from the ambulance service who can come out and who can administer medication and who can alter doses as well as needed, because nobody should be left in that situation.
But for her husband, from his point of view, the pain was unimaginable. He was at the end of his life, and Dignity in Dying say this, of course, who support assisted death, euthanasia, say some people are beyond the reach of even the best palliative care. When it gets to that stage, what do you say to those people?
When you're a clinician looking after somebody and you're not getting on top of their distress, then you need to ask for help from somebody else. Nobody should be so arrogant to think that they can just do it on their own. They need to seek help, possibly from an anaesthetic colleague, possibly from someone in psychiatry, from other colleagues to come in. I'd have to say, from the Cardiff end, we've been completely integrated in the cancer centre. We're seeing patients during their oncology treatments. And now what my colleagues are doing is establishing a dashboard across the whole of Wales to identify deficits where patients themselves can enter how they feel. And if there is an area where care looks as if it's really not as good as it should be, then we can go in and do something about it. This is about continuous improvement. These are things that are happening now. St Christopher's and the Cicely Saunders Institute have set up an impact centre. They're just developing it now to make sure that people can access the best advice as to what to do, when to do it.
So a specific question on what's going on in Wales then. You're talking about the patient themselves and friends or relatives actually administering pain relief when they are at end of life. Have there been any situations on that pilot where it's gone wrong?
No, there haven't been. No, there haven't been. But there have been many situations where people have been relieved. Now, if you think about it, we teach parents to give children insulin, which is potentially very dangerous. Giving people pain relief when you know the dose that they need is not dangerous. The aim is to get on top of the pain and to empower families to know what to do if the unexpected happens is really important, because it puts them in control and it gives them a choice in the care that they're getting.
So of the people on that particular pilot, did all of them die at home? Are many of them still alive? What are the statistics? What's the breakdown?
Well, this goes right back to 2018. So, I mean, they have died.
Right.
But we were monitoring really carefully for problems. And since then, since the rollout, there have not been problems. It's been safe because the clinical specialist team are assessing the patient, working out what they would need just in case, and making sure that it's there. and they're working with the family. The other thing that we're doing is a preparedness project. So before somebody's discharged home, the family are taught not just about the medication, but how to help them get up from a chair, how to help them move, how to help them get to the toilet. So these scary things that we hear about just are avoided.
And that's all brilliant, because that's palliative care for people who are going to die, and it's easing their pain and their discomfort. But that is distinctly different from the choice the patient might want to make about themselves. We had that interview with Dame Diana Rigg, who said any palliative nurse will tell you in the end, patients often starve themselves as a means to an end. The body becomes weaker, the organs shut down. It's not that they want to die that way, it's how they take control. And that was her experience. She said she lost control of her bowels. Her daughter had her in the shower every day, and in many ways brought them closer. But she said it was an undignified way to die, and she didn't want to die in that way. Why put people through that? Why take that choice away from them?
I would say that nobody should be left in that situation. If you've got a situation where you've got such terrible diarrhoea that's going on, then what are the clinicians doing about it?
What if they can't do anything about it, though?
Well, I can't comment on her
But the general deterioration on the body, not individual cases.
Yeah.
This is what we're talking about. People having the right to say, I've had enough.
Right. It's really interesting to see, firstly, in Denmark, their ethics council looked at Oregon and the Netherlands and looked at the experience with a view to possibly changing the law. The 17 members of the council, which was a balanced committee, came out with the conclusion that it is too dangerous to change the law. As a legislator, we have to make sure that the law is safe for everybody. Sadly, in this country, we had the Liverpool Care Pathway. It was very well thought out. It was very carefully intentioned. The problem was when it was rolled out that it didn't work because it got abused. We've had shipmen. I really fear that actually if the law had been changed, shipmen would never have been detected.
But many people listening to this will say, listening to the pilot you've done in Wales,
yes,
is that not open to abuse? I mean, you say nothing happened there, but with less scrupulous people looking after those people with access to those drugs, are you not open to the same kind of risks?
No, because the situation is monitored, the drugs are monitored, the medication given is at the dose that patient needs. And what we do know is pain and distress are really powerful stimulants. And when somebody is comfortable and has pain relief, they can let go of life, and they do. They just let go of life, and they die because they don't have this drive from pain or breathlessness or other distressing symptoms.
I'm going to read you a couple of texts. Lots of people getting in touch, and we thank them for that. I'm 100 years old and in favour of a free decision, and I would definitely wish to end my life in the case of a terminal illness or when my life becomes, in my own assessment, unbearable. I do not want the pain and the indignity of being sent to die away from my loved ones, and I would want to spare them the pain, inconvenience and expense and the uncertainty waiting for me to die. I'm not religious. I refuse that religious people decide what happens to my soul. What do you say to that person?
This has got nothing to do with religion.
But what about their autonomy, their decision?
Okay, certainly that if the nation wants to have a suicide service, then that is up to the nation and the politicians to set it up. But the evidence from Oregon and from the Netherlands, and certainly from Canada, is that by having this as part of clinical care, making ending patients' lives a specific treatment is the most dangerous thing you can do. Canada was told when they started to change the law that it would be really safe, that it wouldn't expand as it had in other countries. And lo and behold, it's expanded more rapidly than anywhere else. And now patients being killed, really, with lethal drugs is the 5th cause of death.
OK, but again, dignity in dying say we're now closer than ever to a change in the law, and mounting evidence from countries like Australia, New Zealand, several US states has exposed opponents' fear-mongering as unfounded. I have to put that back to you very briefly in 10 seconds. What would you say?
We're not fear-mongering at all, and Australia and New Zealand are already beginning to find problems, even though they thought their legislation was tighter. It is not safe. It is just too dangerous.
Baroness Elora Finlay, thank you so much for coming into Woman's Hour. We really appreciate it, and thank you for all your comments on this today.